Recording in progress. Good evening. Amy, I told, and Ariane, I can't see you, but hello. I told Mike this is probably the most stream of consciousness lecture I give, just because it's like trying to do infectious disease for medicine is like let's do a specialty in one day. So it's I think the important thing is I'm going to move at near speed of light, and you tell me if we need to pause or you have a question or something's wrong, or you want to interject. And again, that's true for anybody here. Um, I'm going to share my screen, and I will offer as we start that infectious disease is a very buzzword friendly topic on IT and in the boards in general. Because if you think about it, like they're going to give you a fever usually, and that's the indication that you're dealing with something infectious. And then it really is like, how do you kind of giving you almost like stereotyped clues about how you're going to figure out what's what. Apologies for this slide deck too. It's terrible. Okay. Infectious disease. As I said, I'm sorry. I'll admit first I'm moving fast. And again, it's a bad slide deck. And you're free to ask questions, but there are no kind questions, so just keep that in mind. Okay. Mike, can you read this question quickly, please, in a New York minute?
Yeah. 24-year-old male presents to clinic because he feels terrible. 2 days ago, he developed a fever and sweats. Also endorses headache, fatigue, sore throat, myalgias, and arthralgias. He has no chronic medical problems and takes no medications. He smokes cigarettes and drinks socially. Temp is 38.6, BP is 145/70, heart rate's 94, respiratory rate's 15. He's ill appearing and sweaty. He has a macular papular rash on his face, trunk, soles, and palms. Oropharyngeal exam is notable for a shallow, tender ulcer in the posterior. He has diffuse tender and mobile lymphadenopathy. His lungs are clear and abdomen soft without organomegaly. Aside from a leukopenia of 1.6, his blood work is unremarkable. What is the most likely cause of his current symptoms?
Okay. Yeah, take a guess, or you know the answer. What do you think they're shooting for?
HIV would be my guess.
Yeah. So, I mean, keep in mind that ITE and the boards in general, their goal is for you to not miss important things as emergency doctors. So they're going to disproportionately weight those disease processes which have significant ramifications or have weird pathophysiology that you need to be aware of. So HIV is something that's probably disproportionately tested relative to the prevalence of it, or the ED diagnosis rate, at least depending on where you're practicing. But they're going to test a lot about HIV. And I think really the clue here is that you have an otherwise healthy individual who has a new leukopenia, who has an influenza-like illness. They want you to bite for influenza, but they want you to also be concerned, given the rash, the lymphadenopathy, the leukopenia, that something new is going on, and that this is the nadir of an acute HIV infection. In terms of all things HIV, we can kind of break it up by organ system. So by neuro, the opportunistic infections you want to think about are toxo and crypto. And in general, I'm going to try to focus on buzzwords and things that kind of are associated with these diseases rather than go into the deep pathophysiology. If you're hearing words like ring-enhancing lesions or somebody who just cleaned a cat's litter box, that's your clue for toxo. Whether or not that's actually true is neither here nor there. Crypto, the buzzwords are hydrocephalus or really high opening pressures if somebody chooses to do an LP and they're going to do an India ink stain on it. And again, that's going to be your clue that we're talking about crypto. The treatments are on the side. In some cases, you're required to know these, not necessarily. For ophtho, the big one to remember is CMV retinitis. The important thing to be about CMV retinitis is you have to really low CD4 count for it, like really, really low, basically like no CD4 count.
Chris, I think that's true of crypto as well.
Crypto,
I mean,
yeah, we'll get to this in the next slide. Traditionally, crypto is at a level below 100. CMV is below 50. It's like you're nadering and you have almost nothing less. But you're right, both of them are pretty low in general. And I'll show it on the next slide too. Toxo is a little bit higher. Palm, the big one to think about is PJP, which is probably what we do see in clinical practice still now. The bat wing morphology on chest x-ray, ground glass opacities, the treatment is Bactrim. In GI, there's a number of things to consider. Usually the story here is somebody who has like uncontrollable loose diarrhea. There can be a couple different things. It can be cryptosporidium or isospora, both of which can cause diarrhea, and both will have acid-fast stains associated with them. The other thing they try to differentiate sometimes is people who have an esophagitis, which can be both CMV or HSV or Candida. If it's Candida, you're going to have plaques and it's a little bit more obvious. If it's CMV, it tends to be linear, whereas it's HSV, it's these sort of like what you think about with HSV in general, like sort of punched out lesions that cluster. So again, these are sort of the disease processes or the opportunistic infections that go along with certain HIV or AIDS diagnoses. To Oz's point, these are the classic levels that are taught. 200 is the threshold really that we often think about as the being below that for opportunistic infection, and at which point any of these opportunistic infections constitute an AIDS constituting diagnosis. Toxo is around 100, crypto is around 100. CMV right now is classically is below 50. Again, the boards are going to probably, or the IT are probably going to follow pretty tried and true levels if they're going to give you a level at all. Just something to think about. Oftentimes you're told you have an HIV AIDS patient and you're going to be given some imaging and they're going to ask you to make some diagnoses off of it. Anyone want to venture what these three things are? If you saw these?
Toxo would be one of them.
Yeah, which one do you think is toxo though?
The middle.
You're right.
Middle one would be my guess.
Why are you leaning towards middle?
I don't know.
You're right. You're right. You're actually all right.
But my right one, I think, is what's that pork related?
Yeah, I agree.
Just the way it
Tinea.
looks.
Neurocystic
Right. So the three, good. So great. So neurocystic sarcosis is not actually an HIV related. I just tossed it in here, but it has this weird sort of very distinct, almost looks like PEs if you're looking at a PE scan where you have this sort of hyperdense lesion in the center of a clearing. That's neurocystic sarcosis. That's usually classically in the setting of eating undercooked pork or meat. Toxo is a ring-enhancing lesion. The way you're going to differentiate it from CNS lymphoma is typically the CNS lymphoma picture will only have a single lesion, and it often abuts the FOX, but not always.
And the neurocystic sarcosis is one of the largest causes of seizure disorder outside the United States, like in the developing world.
Right. And so the story for neurocystic sarcosis, again, and the boards are not subtle, nor are they necessarily PC in this. It tends to be like an immigrant or someone from another country who is having this event in the ED. That's your clue that they may have had this process. That often is the case. And again, take that for what you will. Moving on, just in terms of other things, in terms of POEM specifically, this is like a chest X-ray you might see in the setting of PJP pneumonia. It is the most common of the opportunistic infections, though keep in mind that the most common pulmonary infection of HIV/AIDS patients still remains strep pneumo and the other things that everyone else gets, right? So they get the most common things most commonly, but if you're of the opportunistic infections, PJP is the most common for HIV/AIDS patients. The treatment is usually Bactrim, dapsone, or atovaquone can be used as backups. If they have a low AA gradient or they have a low PaO2, that's an indication for steroids as well, and on top of treating them with Bactrim. By contrast, if you saw this chest X-ray, what are they showing you in this chest X-ray? Just as sort of thinking about like, because the stories might be very similar. You get this sort of immunocompromised, chronically ill, acute on chronically ill individual, but you get this chest X-ray. What are we shooting for?
Miliary TB.
Great. And it looks like a little rice kind of all through here. This is miliary TB, one of the versions of pulmonary TB. And again, so there's a whole host of extrapulmonary TB, which we'll talk about later. But this is miliary TB, which is not to be confused, though the narrative may be very similar or the stem may be similar in both instances. This is Kaposi sarcoma. This is one of the more common skin findings that are related to HIV/AIDS. It's important to remember that it can happen at any level. It is actually like HH8 mediated as a virus. Yeah, it can occur in the GI tract, which it can actually be a stem in which you have an AIDS patient with GI bleeding, and they want you to know that it's one of the sarcomas that are bleeding. And the way you treat it is effectively by treating their underlying pathology and putting them on ARB. So that's how it's not treated with any sort of specific therapy related to it. Pivoting, let's talk a little bit about CNS infection since we already were. So you have a 63-year-old man, chronic alcoholism, headache, fever, neck pain. They're giving you a meningitis picture. They ask you, what antibiotics would you like to give to this gentleman? What would you like to give him?
Probably the one that also includes ampicillin for listeria coverage.
Perfect.
Probably.
So, and why are you giving him listeria coverage, Amy?
Because he's old.
Well, he's
No
63 years old. That's rough, but
alcohol.
Easy there, Amy. Easy.
you were right. I would think for the purposes of ITE, this gentleman is on the older side. He's also has a comorbidity in his alcohol use disorder. The answer here is going to be cover him for listeria as well. So that's absolutely right. The way you can kind of think of this is 0 to 1 month, 1 month to 1 year, and then 1 year on. Another way you can also think about it is that for neonates, we're traditionally covering for groupie strep, listeria, and E. coli. Children in the middle group, we lose the groupie strep and instead have H flu, though that prevalence of that is obviously decreasing with routine H flu vaccination in the US. And then as you get into adults, we just go basically to strep pneumo and Neisseria, with patients on the older side additionally having listeria as another etiology. In terms of antibiotic therapy, just remember for neonates in particular, we're supposed to use cefotaxime or something other than ceftriaxone because of a theoretic risk of kernicterus from hyperbilirubinemia with ceftriaxone. So we use cefotaxime plus AMP or Gentin AMP. As they get older, you go back to ceftriaxone and vancomycin, and then you add AMP again in with older patients. If you think it's strep pneumo, which it's hard to differentiate it unless they're very clearly giving you like a smear or a culture that shows otherwise, you should treat with steroids for strep pneumo, or if you have any concern for adrenal insufficiency in a Waterhouse-Friedrich syndrome. So steroids should be kind of part of the bundle whenever you're thinking about meningitis in a patient. ITE and the boards like to ask you to be able to differentiate what you think the most likely pathogen is based off the LP. It can be kind of hard. The way I sort of think about this is I start with bacteria and then I differentiate everything based off of that. So classically with bacterial meningitis, you expect low glucose, which I kind of imagine the bacteria eating glucose. I don't know if that's actually the reason, but in my head, that's the reason. They have elevated white counts, elevated opening pressures, and it's a neutrophilic predominance. Because you have an active infection. Cultures tend to be positive. Viral, by contrast, doesn't have a low glucose. Classically, on a test, at least, it will have a normal glucose. That'll help you differentiate it from the bacterial process. And usually the leukocytosis is not as high. It's kind of like in a mid-range. It doesn't look whopping. They will probably give you a lymphocytic predominance. The reason being, again, they want to help you differentiate it from a bacterial meningitis. In terms of fungal, the main thing to know about fungal is high opening pressures. High opening pressures. That's how you're going to know it. It's going to have high protein because there's a lot of stuff in there. Lymphocytic again. Glucose can be low, but the main thing is you're going to get a wickedly high opening pressure, and it's going to be confusing, especially with things like crypto. If the opening pressure is super high, they're telling you it's crypto. TB can have a variable opening pressure. The main thing to know about TB is the protein's through the roof. So that's how you kind of tell it apart from the other ones. So bacterial, low glucose, high white count, usually neutrophils, viral, lymphocytic, regular glucose level, fungal, very high opening pressures, kind of looks like viral, except the opening pressure is crazy high. And TB is all over, but it's usually the super high protein. That's kind of how I kind of piece these apart in terms of being asked to differentiate among them.
Anecdotally, I got shot in the belly by crypto or fungal meningitis when I LP'd an HIV patient back in the day.
From the force of it?
Uh-huh.
Yeah.
When I removed the trocar, it shot out at me. Thankfully I was gowned.
It may have been using that you were using a chest tube trocar to LP somebody, though. That may be the problem.
He was very altered, but he did not herniate, thank God.
Yeah. If they give you this and you have an encephalopathic picture, or what are we shooting for? This is your head CT. There's areas of hypodensity here.
CVA.
Well, it looks like a CVA, right? It looks hypodense, like there's been a stroke there. This is your kind of given the distribution of it in the temporal lobes, this is your clue in an encephalopathic patient or an encephalitis patient that is probably HSV encephalitis, which commonly affects the temporal lobes. It's going to look like a viral encephalitis. If you're looking for buzzwords, it's going to be somebody who has encephalitis, which usually means fever plus ataxia or seizures. And then when you LP them, you're going to have a lot of RBCs. You're going to have xanthochromia. And they want you to know this one too, because this is the only other sort of thing we typically will add on to our meningoencephalitis therapies from the ED, which is acyclovir, if we're really concerned for HSV encephalitis in particular. So just kind of keep it in your brain too. Don't forget that there are some variations on a theme. If someone's just had a surgery, they can have an abscess, in which case you may need to add MRSA coverage, or if they had ENT surgery, they may also need anaerobic coverage, like they had some sort of sphenoid procedure. They may be selling you neurosyphilis or neuro-TB, though less likely, but think about the diagnoses for those as well. And then there are variations on the VZV HSV theme, which is Ramsay Hunt and disseminated zoster, which you also want to just have somewhere in the back of your brain as possibilities. We can't go into those too much. All right, you have a 9-month-old girl present in the ED with her parents. She's acutely lethargic since last night. She's been constipated for a few days. She said poor feeding, poor suck. She used to be really interested in tolerating breast milk and eating all of her mom's homemade canned goods, but now she's lethargic and floppy and her cry is weak. And what are you worried about?
Botulism.
Yeah, why are you worried about botulism?
Because Amy's a better mom than this person.
The canned foods.
Yeah, why are we being told about canned foods? That's insane. Canned foods is our setup here for botulism. So you're worried about a descending symmetric paralysis, right? So botulism has a number of different forms, often with a preformed toxin. Infantile botulism, in which there was, honey given to a child, is kind of one of the setups, or mom is making lots of canned food. There's a preformed toxin that causes this. The main thing is they have like a weak suck, their feeble cry, they're not handling their secretions, or they've lost their head tone. You can get wound botulism sometimes on the test. It's not as common. Remember that in contrast to things like tetanus, this is a descended flaccid paralysis. It starts up and moves down. You have usually bulbar symptoms, so something affecting the brain stem as well. So you can have diplopia, dysphonia, dysphagia. The treatment of which is both antibiotics, because this is Clostridium, so you need to treat the antibiotics, but you also need to give you need to give botulinum antitoxin as well. There's a difference between equine and human. I don't think that's often tested, but just be aware that that's a thing too, as well. By contrast, there's tetanus, which is, if botulism is flaccidity, tetanus is tetany. You'll always see this 4x4 in textbooks in terms of thinking about when to have to give TIG versus just prophylaxis. The simple way to do it is just focus on this box here, because everything else is just update tetanus, with the exception of if they've not had a full series or they've never had it before, in which case you also have to give TIG. The kicker, and the thing that they'll get you on, is what constitutes a high risk or contaminated wound. Things like burns or crush injuries count as contaminated burns or contaminated wounds. So you have to think about, if you have a burn patient and they've not had a full course, you're supposed to technically give TIG, which we don't always do in practice, but on the test, you definitely do. TIG is tetanus and immunoglobulin. Thank you. All right, moving. And again, stop me if you need to. In the realm of weird things that we worry disproportionately about, given the number of cases we have in this part of the country, we can talk a little bit about rabies. Remember that rabies have to be carried by mammals. They can't be carried by other things like mosquitoes. They can be a very long prodrome because it has to move retrograde up the nerve stem. Things that are closer to the brain have quicker presentations than things that have more distal exposures. Classically, it's the encephalopathic patient with ataxia who's got dysphagia, hydrophobia because of a acute gag reflex. Remember, and this is often tested, if you wake up in a room with a bat, you're getting rabies vaccine and rig if you haven't gotten it before. The assumption is you've been bitten even if you don't have a bite. So if you wake up in a room with a bat after a rough night, you're getting all the things as well. Just keep that in mind. All right. Pause. Questions so far?
Pace is good. Liking it.
Good. We got to move in faster. This is too slow. Let's move. Pulmonary. You got a 53-year-old woman. She's got a history of depression. She's 10 days of productive cough. She's got a fever. She's got some other things. She's got some bilateral crackles. Her electrocardiogram shows normal sinus rhythm with those following features. She's got some infiltrates. What would you like to give her?
Amoxicillin.
You want to give her amoxicillin? Okay, talk to me about that.
Or no, sorry, doxycycline.
What made you change your mind?
I finished reading the options past A.
So we do give amoxicillin, right? The
Yeah.
problem is amoxicillin doesn't really cover atypicals, whereas doxycycline does. And so doxycycline, why not azithro though?
Because that would only be atypical. It wouldn't cover, because azithro, does it cover strep pneumo?
Not particularly well. And in our antibiogram, very poorly, which is why in your probably clinical practice, you aren't just doing monotherapy. The other reason on this particular stem is that the QTC is 525, so they're trying to push you away from a macrolide. These are your common causative agents. Strep pneumo overwhelmingly, less so H flu, and atypicals, mycoplasma as being the primary among them. In our actual practice, we tend to do something that covers strep pneumo and something that covers atypical. So it often ends up being like Amox or Augmentin plus azithro for patients. You can do Levaquin. You could do doxy monotherapy. It doesn't work that well with our particular patient populations, but those are fine. If they're trying to
take a picture of this, because Chris, I don't know if you've noticed this, but if you ask most junior residents what they're covering, they don't know. Now that we have all these pre-prescribed antibiotic regimens for community acquired, hospital acquired, I think that residents have stopped thinking about this.
Fair enough. This is from Roche. I stole all of this stuff from Roche, so you can just keep doing your Roche and you'll be good. But you're right. Sometimes they do want you to differentiate between types of causative agents, and there's some buzzwords. So the CLEB is classically the current sputum, right? It's an alcoholic or somebody with diabetes or who's immunocompromised. Something with Pseudomonas might be like a CF patient. It's somebody who's been on a ventilator. It's somebody who has basically hospital exposure often. The other ones you'll sometimes might see are like chlamydia pneumoniae is the staccato cough. You'll hear the word, like they'll write specifically staccato cough. They're telling you it's chlamydia. Nothing else is called staccato cough. Lots of things probably have a staccato cough. Doesn't matter. That means chlamydia. If they're mentioning they live on a farm, it's Coxiella. It's Q fever. Why? It is. Just know that as well. Same things with mycoplasma is walking pneumonia. Usually in a young person whose chest x-ray looks disproportionately bad to the way they look as well. Keep these things in mind. In many cases, the treatments are the same, but it's worth knowing. Moving. The initial therapy, I'm not going to belabor this. In theory, it's an imacloride or doxy, but often we sort of double cover. Think about risk factors for Pseudomonas. It's usually hospitalization. We have actually moved away from HAP early. We're just in VAP, so don't take too much from this slide. You can use monotherapy with a fluoroquinolone. That's okay too. All right, how about this one? You have a person with cough, congestion, low-grade fever, myalgias, 38.2. Test comes back for flu positive. Who would benefit from getting Tamiflu? I hope you asked about their chicken owning status, DeFilippo. I love that.
They were follow-ups. They both ended up getting admitted and they were both really sick.
Amazing.
And the second time it happened, I was like, there's no effing way. I just had two of them.
That's amazing.
They were not near each other.
Who would you guess?
I'm having a difficult time remembering. So I know elderly and young, but I think it's less than a year. You always give it regardless. But I mean, the guy with 8 days is ridiculous. So I'm between B and C. B, I'm more inclined to give it, but I think C technically because he's within 36 hours or something, right?
So here's the way I would think about this. The answer is actually A because she's pregnant.
She's pregnant. Dang
that's the bottom line. The guidelines, this is from a couple years ago, but the guidelines are effectively the same, which is Tamiflu is most valuable in anyone with serious comorbidities, which include pregnancy, or from historically disadvantaged socioeconomic groups, which include things like Native Americans or people who have poor access to care historically. And children under the age of 2 are always get Tamiflu. the guidelines say everybody else can get it. It's optimal within 48 hours. It is not an exclusion criteria. We all know that the data for Tamiflu in general is kind of weak sauce. But from the purposes of IT, anyone who's getting admitted gets Tamiflu. Anyone who has any comorbidities or is immunocompromised gets Tamiflu. And just keep in mind that it includes things like sickle cell disease, obviously, morbidly obese patients, pregnancy, and the very young as well. Another one to kind of think about in this vein too is pertussis. They like to test this. There are different phases of pertussis. The paroxysmal phase with its whooping cough is the one that we most often think of. This has high virulence, or not virulence is the wrong word. This is a particularly contagious disease, so you want to think about treatment in the rest of the family as well. Classically, macrolides are used, and azithromycin is used in the particularly young as well. Again, the story is sort of the whooping cough or the cough that just won't go away for weeks to months. You think about pertussis. Tuberculosis is obviously tested. We don't see that much of it, or we don't see that much active TB in our patient populations. We see more of it at Lower Manhattan, which is kind of interesting. Remember that there's an initial exposure, then there's an immune response, and then you can become latent and reactivate, or you could clear it. It is an acid-fast bacilli, so you have to use those particular stains in order to see it. I will say again, the boards are not subtle and IT is not subtle. So you're often going to get kind of a stereotyped and unfortunate story of this patient coming from a prison or a shelter or being born outside the US as a reason for them to have TB. And granted, like 3 billion people in the world have TB, so that's not crazy. A lot of the world does have TB. They will often have B symptoms of night sweats and weight loss. They will have hemoptysis, and they will typically have some sort of abnormal chest finding on their chest X-ray. The treatment is ripe, as you also want to give isoniazid in case they have latent TB. Remember that if you're doing tuberculin skin testing, which sometimes come up, the more immunocompromised you have, the less response you have to have from the PPD in order for it to be positive. So, for example, if you're HIV positive with uncontrolled or AIDS, you're going to or an immunocompromised patient, we're going to expect you to have a much more muted immune response to the PPD, and it can be smaller as a consequence. The place people get hung up is kind of in the middle ground, knowing who falls in that 10 millimeter category. I think often we think about people who are high risk in general for infection and or people who engage in high risk behaviors, which is another way to think about it. There are a number of mimics that they like to use on the test as well. So one of these is TB and one of these is not. Which one of these is TB?
Is TB? I would say the left one.
Why are you leaning towards left?
Looks more cavitary in the upper there, and maybe a middle lobar pneumonia in addition to the cavitary lesion.
Okay, so you're picking up on something important, which is this pneumonia seems to be middle lobe. It's hard to tell, obviously, because it's a single film, but it doesn't look apical, whereas the other one tends to look more apical. The other thing, so the one on the right is actually TB, and the reason is it's because it's apical. That's where we're classically taught it is. The one on the left also looks like it has an air fluid level. I don't know if you can see my mouse, but like there's a clear sort of line here, which is more common in like a MRSA pneumonia. So it was a good guess, but in this case, this is why I'm showing this is because you can get fooled by lung abscesses. Your TB is going to be in the apices. That's just where they're going to put it to make it clear for you. How about this one by contrast then? This looks like somebody aspirated a peach, but it's not.
You have mediastinal shift away. My guess would be a tumor or something.
Yeah, a tumor is a good guess. Like if you had like a Pankos sort of thing, it's very circumscribed though. That's the weird thing about it. The story you're going to get somebody is who has like really bad COPD, has been hospitalized multiple times. This is an aspergilloma, where again, very circumscribed, like looks like something has just been sort of glommed onto the lung. And it's more discrete than TB, which is less organized as a thing. Which brings me to fungi in general, just to talk about them. Sometimes this is tested, it's worth considering them. Aspergillosis is always somebody with an extensive pulmonary history. That's how you're going to know it's them, and they're not getting better, even though they've been treated for a million things under the sun. And then they have this very circumscribed lesion. They're selling you aspergilloma. Histo is a story of somebody who went into a cave and was spelunking, and now they have hemoptysis, or they were inhaling bat droppings. There's going to be a lot of weird clues that to make it specifically histo. But it's hemorrhagic, which is the thing that differentiates it really from these other types of fungi. Coxy, think Southwest. It's somebody who's coming from New Mexico. It's somebody who has inhaled a lot of desert dust. They will have like enodosum often. They're going to have organometably, but it's going to be the Southwest thing that clues you in to this being Coxy. And Blasto is usually like a Southeast US thing. The lytic lesions are the things that will often tip you off. They have lytic lesions where the other fungi don't. They can also have like what are called like cannonball lesions in the lung. It almost looks like septic emboli because they just sort of like plug away at the lung. If I showed you this, what am I showing you other than something horrifying?
Just had one of these a week and a half ago.
Did you really?
Yeah.
Wow.
Post transplant patient.
Right. So this is always a very immunocompromised patient. Classically, it's a diabetic on tests, but it could be a transplant patient. This is Mucor. This is no bueno. This is a necrotic process that's invading into the skull base and has extremely high mortality. And this is treated with shake and bake. This is amphotericin and fluticasine. This is all pulling out all the big guns to treat this.
Yeah, it was a refractory sinusitis, and then came in at week 3 for my nose is turning black.
Yeah. It is bad. How about if I showed you these two? One of them, the one on the right is TB, but what's the one on the left?
Either septic emboli.
Mets?
So
Mets are a good choice. This is septic emboli. I actually had one of these at LMH where the chest X-ray looked literally like this. Maybe a month or so ago. Very sick dude. Infective endocarditis, remember, they often will test whether it's right-sided or left-sided. If it's right-sided, it's an IV drug user on a test. That's just the way it is. And it infects the tricuspid valve, and it's almost always Staph aureus. If it's left-sided, meaning they have all of the things from Jane, like Janeway lesions and a murmur and Osler nodes, it's usually because they have a valve or some sort of congenital defect, like a bicuspid valve. And it's also the Hasek bugs and all of the weird stuff that you get, or can be odontogenic. But right-sided, think IV drug use. Left-sided, think systemic findings and probably viridins or some sort of mouth flora as well. All right. Pause real quick. Questions about any of these things or observations or things you're like, you got this wrong, because it's totally plausible. All right, let's roll. GI bugs. You got a lady. She went to a Chinese buffet. She ate. Now she's vomiting. She's got diarrhea. No fever or blood. What do you think is causing her problem?
Bacillus cereus.
Because
Not to sound stereotyping, but refried rice.
yeah, again, the boards are not culturally sensitive. You saw a Chinese buffet, they're selling you be serious. They're selling you a preformed toxin, often associated with refried rice. How true that is, I don't know, but that's how it's tested, and that's how they're going to clue you in. She wasn't at a Greek diner, right? So, non-invasive gastroenteritis. There's two flavors. There's non-invasive and there's invasive. Viral is exceptionally common. It's usually noro and usually rota. It's fecal oral. Giardia, it's going to be somebody who camped and then like sat by a beaver dam and drank water. They're going to have tons of flatulence. It's going to be very foul smelling. But it's almost always a camping story that sets it up with like flatulence. That's how you're going to know they're selling you Giardia, and they'll show you like motile things when you look at the slide, like any of us are doing slides. Staph aureus, preformed toxin. It's always somebody who went on a picnic and ate some mayonnaise or had some cured meats or something like that. That's how they're going to tell you. It's a rapid onset. It's like within hours of eating, you are vomiting and you're having diarrhea because it's preformed Staph aureus. Be serious. Refried rice. That's usually the one they want you to know. Clostridium perfringens is usually cooked meats, and Vibrio is seafood. It's oysters. That's what differentiates it from the other ones. It's a seafood picture that you're getting. With explosive rice water diarrhea, which is cholera. So kind of keep that in mind. By contrast, the invasive gastroenteritis, the things to know about here are the ones that kind of show up. Salmonella, you can get this sort of light salmon rash, as it's called. You can get temperature pulse association with salmonella infection, meaning you have a huge fever, but your pulse doesn't go up accordingly. Shigella has Shiga toxin associated with it. Campylobacter, the most common cause, undercooked poultry. Remember, this is the one that they will often use as the setup to a GBS story down the road when they have some sort of weird acute idiopathic demyelinating process. Yersinia can look a lot like appendicitis. It can be a pseudoappendicitis, which is sometimes the story you get. Entamoeba histolytica, the story you're going to get there is liver abscesses. They're not going to really give it to you as an invasive diarrhea. They're going to tell you that this person has a mass in their liver and they came from Mexico. That's like always the story. And the trick is don't put a needle in it. They're going to ask you, do you want to put a needle in? You're going to say no. And then EHEC, which is somebody who ate a burger and then started having bloody diarrhea. And it's the one that we often think about in the setting of hemolytic uremic syndrome. The one thing about most of these is they don't want you to treat these with antibiotics unless the patient is really, really toxic, because with Shiga and a number of these others, you can develop HUS, especially in children, less common in adults. Salmonella is also the one to think about in terms of a Reiter syndrome, which is now reactive arthritis. Reiter was a Nazi, we don't call it that anymore, but basically reactive arthritis where now they have, can't pee, see, or climatry. So salmonella is often the cause of agents in those as well. Same thing with Campylobacter. C. diff, ignore some of the details on the slide. I stole it from Roche, but the guidelines have updated. So we think about C. diff in somebody who's had administration to antibiotics with frequent watery cramping stools, sometimes with blood. They sometimes want you to get an abdominal x-ray to make sure they don't have megacolon, especially if they look toxic. Remember that metronidazole is out now. It's just Vanc. You can fidaxamine. Can't remember how to pronounce it. There's another agent, but basically it's Vanc for all. We're out with metronidazole for these patients. Eventually fecal transplant down the road, but it's PO specifically because it does Vanc is not systemically absorbed. Just keep that in mind. All right, how about this guy? You have a 26-year-old guy. He has fevers, malaise, joint pain. He has a rash of 39. He's got a couple palpable purpura on his skin as well. What are you worried about with somebody who has palpable purpura and he's 26-year-old?
Meningitis.
So you should be worried about meningitis. Purpura is always bad. Like anyone with purpura is bad. So you should think about meningitis. Though the only thing about meningitis is we don't really have like an altered picture here. I've read very quickly, and he's not meningitic, which they want you to think about it because you can have meningococcemia with purpura or purpura fulminans, which can happen in sepsis in general.
I think with his migratory arthritis, I would be leaning more towards gonococcemia.
Right. They're looking for gonococcemia. This is disseminated gonorrhea right now. Moving on to GBU in general. So gonorrhea, you can have all of these things. Remember, we're empirically treating for chlamydia when we treat for gonorrhea, and we're treating for gonorrhea when we treat with chlamydia. Ignore the bottom of this slide. We're no longer using azithromycin. We're using doxy because of resistance, with the exception of pregnant patients who can't get doxy, in which case azithro is unacceptable. But the days of a shot in your butt and a gram of azithro and you're good to go are over because of resistance patterns at this point too. Chlamydia is the close friend of gonorrhea. They hang out together a lot. You're going to have cervical discharge. Again, doxy is the treatment, 100 milligrams BID times 7 days. Do not give azithro unless in pregnancy. You can think also about other sort of GU-related pathology like BV. Sometimes they'll test the AMSL criteria. It's just important to remember that the whiff test is not exclusive to AMSL criteria. Sometimes they use that as like a way of kind of fooling you. You expect the pH to be higher because this is altering the vaginal flora. And if they're giving you sort of a BV picture, but they have a frothy greenish discharge with a strawberry cervix, meaning like a micro hemorrhages to the cervix, they're telling you it's trick. Remember with trick, you have to treat the partner as well. And if you're having trick in a patient who should not be sexually active by virtue of age, you have to alert Child Protective Services because this is only a sexually transmitted disease. You cannot get trick naturally. So that's another sort of like catch they'll use. Sometimes it'll be like a 4-year-old with trick, and that's supposed to be your red flag that they're being abused. Treatment is Flagyl for both of these, just in terms of BV and trick. Prostatitis is often the male version of this. Remember that people under 35 are sexually active, and so that they are treated for gonorrhea and chlamydia. People over 35 stop having sex, so they are treated for other causative agents such as E. coli or fusiform bacteria in general. The way you're going to know that they're telling you it's prostatitis rather than an actual cystitis is the patient might have some dyschezia and some or tenesmus. They'll have been treated for a UTI and not get better. And then when you do a prostate exam, they have this boggy, tender prostate. There's some debate in clinical practice whether you really should do this exam, because do you seed the blood by doing the manual prostate exam? On the test, they'll do it and it'll be boggy. And the thing to remember is you have to treat for a really long time. You have to treat for 4 to 6 weeks, either with Bactrim or something like Levaquin or Cipro. But remember, the age distinction is the thing they want you to do. PID is the invasive version. So the way I think about it is like PID is the pyelo of GU complaints. So like cystitis is the local one, and pyelo or ascending urinary tract infection is the complication. Chlamydial infection and or gonorrheal infection is the sort of lower tract infection, and then the upper tract infection is PID. They're going to tell you there's CMT. That's really your clue. There's a chandelier sign, right? Like you move the cervix, the patient jumps to the ceiling. Those are the main things you want to, or they have really severe adnexal tenderness with an infectious picture. These patients can be treated outpatient. They need ceftriaxone. They need doxy for an extended period of time. Inpatient, they often get cifotetin. I don't know why. It's just like, why do you give diclox for mastitis? You do. Why do you give cifotetin for PID? You do. That's the answer they're looking for here too. But again, the treatment course is longer because it's ascending into the upper GU tract in women. You might want to think about getting a ultrasound on these patients too. We often do in clinical practice to make sure they don't have a tubo-ovarian abscess. It's going to be the same story as PID, except they just look sicker. And you want to be aware of it. And these patients get admitted. It's often polymicrobial, which is interesting too. Syphilis is highly tested, even though we don't see, well, actually I take it back. We see it a lot now. We don't see the later sequelae of it as we classically did in medicine, but we are seeing a rise of syphilis, certainly in our MSM population. Remember, it starts with a chancre. What differentiates the chancre from these other lesions is it's painless. It's usually a single lesion. That's in contrast to something like Haemophilus ducreyi, which is a very painful lesion, or something like LGV, which usually is unilateral tender inguinal lymphadenopathy. That's kind of the way I keep it in my head is like syphilis is painless, Haemophilus ducreyi is painful, LGV is adenopathy. That's kind of the way they're often tested. LGV is just a serotype or serovar of chlamydia, one of the chlamydias. Secondary syphilis is the one with rash. Remember, it's one of the few rashes that goes to palms and soles. So if you see it, you should be thinking about it with a good story for penicillin, for syphilis. The treatment always remains penicillin G. If you are a pregnant woman with a severe penicillin allergy, the treatment is what?
Still penicillin.
Still penicillin. You desensitize them. You really need to give them penicillin. And then sometimes they'll test you about the Jarix-Herxheimer reaction, where you get sicker because you're lysing the triposomes as they die, and you can get sort of an acute cytokine mediated reaction. How are we doing on time? 12 minutes. All right, moving. I'm going to skip this. Basically, in practice, we send RPR on people, and then you can move to like an FTA antibody. That's the most common one. Keep in mind, it can be falsely positive in lupus patients for whatever reason. Just something to think about. In terms of UTIs, we mostly know how to treat these. I don't think these are things that usually need too much details. Think about cystitis versus pyelonephritis versus pregnancy. Things change in pregnancy. MOX. Bactrim is not the best. Basically, it's a MOX, nitrofurantoin, and furantoin are our go-tos in pregnancy for UTIs for pregnant patients. In terms of skin and joint things, what is the most common finding in patients with septic arthritis?
I'm gonna guess C,
Which one?
but I feel like I'm gonna guess C, but I think like the pain with range of motion is how we really differentiate it, but I'd guess like the most common finding is swelling.
It's pain with motion, and that's actually why we pay attention to it. You're totally right. Like if you want to get a orthopedic doctor's attention about septic arthritis, just say they have pain with micromovement. Like that's the buzzword for them. You may be wrong and they may disagree with you, but if you want to get their attention, say like I try to move them even just a little bit and they scream, and that's what for them means septic arthritis. It's pain with through the passive range of motion. The boards like to test whether or not you can, when you tap something, do you know what you're looking at? Just remember that if you think it's septic, it's really got to be over 50,000 WBCs. That's kind of your threshold. And there's often pus that can come out of it. They're not going to test you about like synovial lactate and stuff like that. That's not part of it. In most people, it's Staph aureus. That is the most common thing. If you are like a sickle cell patient and you have splenic dysfunction or you're asplenic, you have to think about encapsulated organisms, including strep. And then if you have the story of the 26-year-old with joint pain, you also might need to think about Neisseria as well if you have a kind of clinical picture that they're selling you that's a little bit more than that. Neck fash is another soft tissue we need to think about. There are 3 types of neck fash. The most common is polymicrobial. You broadly treat vancomycin and clindamycin to scavenge for toxin. Group A strep is the other type. It's less common, is particularly deadly. It moves very, very quickly. And the third type is Vibrio. So if it's somebody who's like clamming, that's a story like they're doing like clamming in like New England and they cut their toe and then suddenly they're dying. They have Vibrio, the treatment of which is Doxy. They're telling you it's neck fash when you have pain out of proportion, or you have pain that is preceding the affected skin. So like the rash is in point A, but the pain is in point B. That's neck fash. That's what they're telling you. Hemorrhagic bullae is also one of the kind of code words for this. They want you to make this a clinical diagnosis. They do not want you to get any sort of imaging. They want you to just call your surgeon to have this treated immediately. With broad spectrum antibiotics, just FYI. Another one that sort of comes up that we don't actually diagnose that often because it doesn't really make that much difference is erysipelas. Erysipelas is different than cellulitis because it's more superficial. The classic feature of erysipelas is that it involves the ear. It's called Millian sign, and that's because the ear doesn't actually have deeper soft tissue structures. So if you have a cellulitis of the ear, it is erysipelas. Like that is the pathognomonic for erysipelas. It can sometimes cause this butterfly pattern across the face. You may think like, am I getting a lupus picture? But it sounds sort of infectious. It doesn't really matter because you treat them the sort of the same way. But if it's involving the ear, they're cluing you in that they want you to say this is erysipelas, and it's often strep rather than staph. That's the other thing to know about it. Toxic shock is another one you're going to see. It looks like somebody who's got a wicked sunburn. It used to be on test that we tested in young women with like a tampon because of these ultra absorbent tampons. That was the story. You may get a story because that's not a thing as much now. You may get a story of somebody with a foreign body. So like a kid who went out, ran around in the yard, got a foreign body, didn't tell mom or dad, and now has this diffuse erythematous rash with desquamation and has multi-organ system dysfunction. Think about it as toxic shock, treat it. It's pretty dangerous. Again, you want Clinda for scavenging. And I agree with you. Anyone who's just not getting better, the rash, it has to be erythrodermic. It has to be an enormous rash covering a lot of skin. That's your clue for toxic shock. Flexor tendinosynovitis. Do you know Canaveral signs? You should know Canaveral signs.
Fusiform swelling.
1.
The digit held in passive flexion.
Perfect.
Pain along the tendon.
Great.
And pain with extension.
Yeah, exactly. Which kind of makes sense, right? It looks swollen. It hurts when you touch where the sheath is. When you keep it flexed because it hurts, and when you extend it, it hurts. The 5th Canaveral sign is orthopedics does not think it's tenosynovitis. That's your other clue. If you think it's tenosynovitis, they don't think it's tenosynovitis, and vice versa. But keep this in mind. This person gets admitted. This person gets unison. This is not like a felon. This is a person that needs to stay in house for treatment. All right, tick stuff. Tick stuff gets tested. I'm going to fly right now. It is really not important that you know the distinction between all of these. You're never going to be asked, is this babesiosis or ehrlichiosis? Just not a thing. But know that there are multiple tick diseases aside from Lyme. The story for Lyme is you can get it anywhere in the country, not just Lyme, Connecticut. Stage 1 is the erythema migrans. You're going to the bullseye you're going to see. You could also get a story of myocarditis, of heart blocks, of Bell's palsies. There's lots of different things. This is the erythema migrans rash. It looks really like a bullseye. There should only be one of them. That's your clue. It looks like a bullseye and there's one of them. If there's any sort of weird conduction delays, they're telling you it's Lyme. Lyme can have variable conduction delays. So you can have a delay and it resolves and it comes back again. If they're in complete heart block, they're probably telling you it's Lyme. If you have a bilateral palsy, Bell's palsy, it is Lyme. That is pathognomonic for Lyme. Nothing else does bilateral Bell's palsies. So if that's the story you're getting, it's either like PD with masked facies or they have Bell's palsy. Sometimes you'll get rashes that look like erythema migrans, so it's important to know the difference. Does anyone know what the one in the middle is? Serpentiginous. The clue is they're going to call it serpentiginous. So this is part of the Jones criteria. So this is erythema marginatum. So this is basically part of rheumatoid arthritis. This is acute rheum. The one on the other side, what do you think that is? On the right.
That looks like a tinea infection.
Right, exactly, because it's scaly, right? It's scaly along the leading edge of it. So that's tinea. So and the one on the left looks a lot like Lyme, except there'd be lots of them. And this is erythema multiforme. This is a drug reaction or it's a viral reaction like EBV. So if you have more bullseyes, then it's EM. If you only have one, it's Lyme. Beware a marginatum, which sometimes shows up. If a patient has a tick on them and they pull it off within 36 hours and it's not engorged, you don't actually have to treat them. But if you're going to do prophylaxis, it's a single dose of doxy, 200 milligrams times 1. If they have any sort of other involvement, it's doxy. And if they look sick, think about ceftriaxone. That's basically what I'll leave it with these. The other tick-bornes we need to know about are things like Rocky Mountain spotted fever. Rocky Mountain spotted fever is found throughout the entire U.S. It is a centropedal rash. That's what's going to distinguish it. It moves from the palms and soles in towards the torso. It has often petechia. A lot of these tick-borne illnesses have thrombocytopenia as well as LFT abnormalities. That's going to be your clue that we're dealing with something tick-borne is LFT bumps and thrombocytopenia. The treatment is doxy for a lot of them. Ehrlichiosis and anaplasmosis, same thing, but babesiosis, same thing. Think about LFT abnormalities, cyclical fevers, thrombocytopenia, and some sort of exposure. Think tick. That's really what they want you to get. Traveler's bugs, malaria, real quick, worth saying. Falciparum is the one you really have to care about. Chloroquine is fine in a lot of areas, but for most patients, they're going to need something stronger. The new increasing drug is artesunate. That's the one that's used in a lot for really serious malaria patients. It's going to be a story of cyclical fever. You might get a thin and thick smear, so far and so on. I'm moving quickly. I'm actually almost done. Hantavirus, super weird. There's actually 2 flavors of hantavirus. There's the Korean hantavirus, which Chris Kim loves to talk about, and you should ask Chris Kim about it because he actually really cares about it. The Korean version is a hemorrhagic fever. It's like Ebola or Lassa, super deadly. The pulmonary version of Hanta fever is pulmonary. So it's a story of somebody who like lived in a house with mouse droppings, and then they develop like a fulminant ARDS picture. And that is hantavirus. If they're coming from the West and you hear the word like mouse droppings, they're telling you it's Hanta. And the treatment is just supportive care for whatever it's worth. There are lots of other things that have buzzwords in them. Ebola, think about hemorrhagic fevers. Chagas is the kissing disease, right? So a kid who comes in with a swollen eye, they can develop achalasia with a bird beak deformity. They can also develop cardiomyopathies. Leptospirosis is a person who's on a cruise ship. who has a GI bug. If they have a lot of like ocular involvement as well, it may be whale syndrome. Something to think about too. Again, it doesn't really change a lot of what you're doing, but it's freshwater swimming too. There are other things too: West Nile, Eastern equine, dengue, breakbone fever, severe myalgias, African sleeping sickness is trapezomal as well. I can't get to these. There's also worms. I'm not even teaching. I'm just saying words at this point. Think about pinworm is the Scotch tape test. The kid who has like perianal itching at night is your Scotch tape test. Anasarca has eosinophilia, a persistent cough as well. That's because the worms are climbing up out of your lungs into your esophagus, which is kind of gross, but it's eosinophilia. Keep that in mind too. Flukes cause river blindness. The treatment of it is the same treatment for COVID. It's ivermectin. So keep that in your brain too. Flukes, but is the leading cause of blindness in the world outside of the United States. Keep that in mind too. Roundworm is again eosinophilia. You're not going to get more than that. And that's what I got because it's also 9:30. Questions on any of these things?
Masterfully done, Dr. Rice.
That is all infectious. Congratulations, you have done fellowship. You're now officially ID doctors.
And we have it on recording now that you're one of those crazy ivermectin.
Look.
Hydroxychloroquine docs.
I didn't say that. I didn't say that. I'm just saying truth is out there.
Thanks so much, Chris. This was great.
No problem. Thank you guys.
I'm gonna have to
any questions, guys?
I'm gonna have to invite you to do more than one.
You made me do another one. I'm
I
doing the
know.
home one. You act like you didn't do that.
I think I'm gonna turn the whole thing over to you.
No, it's fine. Anyway, thank you guys. Amy, thank you for joining. Thank you guys from, I don't know, John Paul, I don't know what programs you're from, but thank you for joining as well.
Thank you.
No problem, guys.
And next up, Diksha Mishra.
Hi guys. Okay.
Bye, Chris.
Bye, guys.
Thank you. You
All
want
right.
to give them a pee-pee break?
Yeah, I think that's
No, no one peed. Yeah, this is a lot. 2 hours of review. It's a lot. And that too, ID as well as N.
All right. Next up, we have Dr. Mishra doing metabolic and endo emergencies. Thank you very much.
Absolutely. Just so you guys know, there's a lot of text on most of these slides. And that's more so because I know Oz or somebody will share we'll share this with you, and that way you just have all the information that you need in one space as opposed to having to look elsewhere. Metabolic and endocrine emergencies. I truly believe this is very boring. The only way I think you can make it interesting is by looking at Awkward Yeti comics and by thinking about it as a story. Like the stuff that I really find hard to learn or do, I try to think of it just like kind of as a process, and I tell myself a story about it, and we'll kind of talk through that right now in terms of how that'll work, and focus on the big things. So we're going to talk about cortisol, aldosterone. So aldosterone, can anybody tell me what the point of it is? What's the point? Why is it there?
Saves your sodium and makes you pee your potassium.
Exactly. So sodium goes into the blood. Because the sodium goes in, water follows, right? Can help maintain your pressure, and then it pees out potassium. Potassium goes away and hydrogen ions go away. Okay, perfect. Adrenal gland is the one who manages this. Okay, and then cortisol does a whole gamut of things that we're going to talk about. So I want to talk about low cortisol issues, and I want to think of it as a story. So primary adrenal insufficiency. How do you break this word down? What does this mean?
Adrenal gland is the problem.
Yes. So when it's primary, it's the actual gland itself that is the issue, right? And then these are all our characters, right? So we have the hypothalamus. The hypothalamus releases CRH. Great. Releases CRH into the pituitary gland. The pituitary gland in turn releases ACTH as well as MSH. MSH gives us pigment. ACTH goes and does other stuff, which is where it goes to the adrenal gland, and it releases cortisol. Okay. You have all the characters, you have this nice thing here. If you remember this, then you can start to think about how all these components lead to these things. So in primary adrenal insufficiency, the HPA axis, this hypothalamus gland axis here, is working fine. It's just that the gland itself isn't making cortisol. So then we talk about the feedback loops. We remember all of this from, back in the day. You have the feedback loop. If there's less cortisol, that means that there's less inhibition to have all of this stuff come out. So you have increased ACTH, you have increased MSH, you have increased of all of these because the cortisol is not inhibiting it from being made. As a result, one of the key things with primary adrenal insufficiency is that they have hyperpigmentation. That is going to be where your question lands. Quite frankly, it's these key words, and that's where it's going to be. So hyperpigmentation is seen here because here the gland itself is not making cortisol, which means you have increased ACTH, you have increased MSH, and you have hyperpigmentation. Okay. Along with that, you're also going to see these aldosterone things. You're going to see hyponatremia. Okay. So that means what? If it's hypo, then what's going on with the aldosterone?
Not being produced.
It's not being produced, right? So you have hyponatremia, hyperkalemia. Those are going to be opposites when it comes to that, and hypoglycemia. This is because the cortisol is low. Okay. Do you need to know the most common causes of things? This is going to be Addison's, which is basically autoimmune, where your body will just kind of kill its own adrenal cortex. And then elsewhere, apart from the US, it's TB. Something to keep in mind if it's a part of the whole text that they give you. Secondary adrenal insufficiency is
something else causing the gland not to work.
Exactly. So the decreased cortisol is because the hypothalamus isn't working, the pituitary gland isn't working. Remember we said CRH, ACTH has to get released to make the cortisol. One of those other guys is not working. That's why it's secondary. Given that, typically, this is because of exogenous steroid use. Here, you typically will just see hypotension, hypoglycemia. You don't get any of the aldosterone thing. You don't get the hyperpigmentation thing. The reason you don't get the hyperpigmentation thing usually is because you're not making enough ACTH. You're not making enough CRH. And so you're not going to see that. Okay. So key things here, common causes, and the hyperpigmentation. And then this nice little story that you can keep for yourself. Okay. In terms of just the diagnosis and treatment, you just need to know it. It's a corticotropin stimulation test. This is basically just CRH. CRH that the hypothalamus releases is corticotropin releasing hormone. So you're basically going to see if you give that and what happens and if it works or doesn't work. Hydrocortisone will mess this whole test up. So in real life, don't give hydrocort to these people if this is going to be a new diagnosis. This is just something to keep in mind. Treatment-wise, you give hydrocort. Otherwise, you can give Dex. You have to give fludrocortisone with it. A key to remember with Dex is that it does not have mineralocorticoid activity. Mineralocorticoids are aldosterone. That's where that falls into that category. Glucocorticoids, cortisol. You give everyone fluids, mostly everyone. We will kind of talk about who won't get fluids in certain things. What's adrenal crisis? And what do you do for it?
Essentially, the way I like to think of it's like refractory shock secondary to adrenal insufficiency.
Exactly. So you have adrenal insufficiency. You have some sort of adrenal thing. Sometimes what can happen is that you're taking exogenous steroids and then you abruptly stop. That's the key kind of case that they may give you. And then you go into something called adrenal crisis, which is where there's some sort of outside stressor, be it that you stop taking exogenous steroids and then you have an infection, or then you have an MI or whatever it may be. And then you have low cortisol, you have low catecholamines, everything collapses. This is where it comes in. You get hypotension, shock, fevers, etc. The fever is more so because it's a thing that's causing it, but you get hypotension and shock. What do you give for this?
Fludrocord. You can get like any, you still do standard resuscitation, IV fluid, pressors, but it's usually refractory to that.
Right.
So hydrocort or fludrocort, 100 of hydrocort
Per the test.
or 50.
Yes. So hydrocort, you can give 100. But so essentially, for the test, you will have given them fluids, you will have given them pressors, and then they're going to ask you what else you want to give. And that's when you're going to give hydrocort, dex, fludrocortisone, whatever you need to. In real life, if a person is not doing well and you're giving them fluids and you're giving just give them hydrocortisone if you're like worried about it. Don't follow this perfect algorithm in terms of when it needs to go. I needed to give them 3 liters of fluid and then I had to give them this. Doesn't follow that. If you're worried that they're having some sort of an adrenal crisis, give it to them. That's the main thing I would remember there. Hypotension is big here. If you start to see hypotension that is very severe, you need to think of adrenal crisis in those cases. Okay, now we talk about the cortisol being high. So we have Cushing syndrome. Who can tell me about Cushing syndrome? What happens?
Essentially, things slow down. The way I like to sort of think of it, start getting like weight gain. I forget the specific like etiology of it off the top of my head right now, but you get like buffalo hump, weight gain, lethargy. That's about where. Yeah,
absolutely. So they're going to talk about this like abdominal striae that you get these fat pads in places, you get these moon faces, obesity, etc. The most common cause is taking steroids. That's the most common reason why this happens to people. So iatrogenic cause is what we think about. The second most common cause is Cushing disease. How much more confusing could they have like actually made that? There's Cushing syndrome and there's Cushing disease. I don't know who thought of that. I think it's crazy. But Cushing disease is when the pituitary gland or there's a cancer or something at that region basically secretes too much ACTH. If you have too much ACTH, your story tells you, goes to the gland, leads to more cortisol, right? So in that case, it's called Cushing disease. Is it going to be relative to your test? Probably not. Something to keep in mind. And then this is a whole laundry list of things. I just try to remember this person. And I think it really keeps it helpful for me. In terms of the diagnosis, it's a urinary cortisol, a 24 urinary cortisol excretion. Management wise, for iatrogenic, you taper off gradually, taking whatever exogenous steroids you were taking. Cushing's disease, if it's a pituitary adenoma, you have to take care of that. And then there's medication therapies as well. There's been 1 or 2 questions on this through like Ross related to like ketoconazole. The question is really just asking you to recognize Cushing, and then they'll ask you what you need to do. And typically it's going to be one of these 3 things. You just have to recognize which one it is. Any questions so far? Cool. Adrenal gland makes sense, hopefully. I'm going to just kind of rush through this part because I think there's just some key things to remember. You have pituitary tumors, you have a prolactinoma. It's when prolactin is released. Okay, when there's a lot of prolactin, you can think of it related to infertility, galactorrhea, amenorrhea. Essentially, it's thinking of a person who is currently like, creating a lot of milk. When they create a lot of milk, they won't be having their period, and they're going to be infertile. So those are kind of the 3 things to keep in mind. The classic thing that everybody talks about is that they'll have bitemporal heminopsia. Does anybody know why and what that's related to?
The pushing on the optic nerve.
Pushing on the optic
Chiasm?
chiasm, exactly. So the pituitary gland kind of sits right on top of the optic chiasm, and so it pushes on the optic chiasm. So quite specifically, it's right here, number 2, where you have the lesion. This is the optic chiasm. So then the pathways that are going across are going to be basically affected. And so you're going to have vision right here. And that's what we like think about. You guys can look through this as well. So that's also a classic thing with a prolactinoma. Another key point to remember for the test. Pituitary apoplexy, you're basically bleeding into the gland itself. It's like related to all of these things as well. You get this really bad headache, something to keep in mind when you think about people with bad headaches. You give them steroids and you call neurosurgery. That's really it. I'm trying to think if there's another main point to that. Not really. Thyroid. Great. So let's go through a question. So 49-year-old male is admitted to the hospital because of some sort of infectious stuff. He had basically like there was a wound from a saw. So he has a history of hyperthyroidism, but reports a lack of medication compliance. He was improving until day 2 of staying in the hospital, where he was found to be in respiratory distress, tremor, agitated, febrile, tachycardic, blood pressure is a little low, respiratory rate's a little high. What do you want to give this person?
I'm guessing it's propranolol, but that wasn't only because I know the topic right now. It took me a little longer to actually realize what was going on with this patient.
Yeah, so it's propranolol. Essentially, the way they're going to word these questions is they're going to somehow tell you they have some sort of endocrine issue, be it thyroid related. They may even just write it up here, 49-year-old male, medical history of hyperthyroidism. That may be all that they actually give you. And they'll give you this sort of presentation where the heart rate is really high, the temperature is really high, the respiratory rate is high, the blood pressure, and they'll give you this sort of very general picture of somebody who's septic, of somebody who is generally unwell. And it'll be your job to try and figure out if they're having thyroid storm, which is what we're going to talk about right here. So before we get into that, hyperthyroidism, hypothyroidism, I think it's very clear. We go back to our story. Hypothalamus releases TRH, which goes to the pituitary gland, which releases TSH, which goes to the thyroid gland and releases the thyroid hormones. Pretty simple. Once again, primary, you're going to have an issue where you have a lot of thyroid hormones. So primary hyperthyroidism, the gland itself is making too many thyroid hormones. So then you're going to have low TSH, etc., and the opposite. Okay. And then just the causes of this, to know that Graves is the most common cause of hyperthyroidism, to know that Hashimoto's is the most common cause of hypothyroidism, that you see sinus bradycardia with hypothyroidism, you see sinus tachycardia with hyperthyroidism, keeping these sort of patterns in mind, which I think you guys already know just from practicing every day. So the question with thyroid storm is going to be the management. So can somebody walk me through thyroid storm? Just walk me through it. What's the question stem going to be, and what are you going to do? I'm sorry, Amy, that you're the only one I see, and now you're the only one I'm talking to. But if anyone else wants to gander.
I can start it. It's not something that I'm, the most comfortable with. But so basically these are really sick patients. And I know that there's an order to the medications you're going to give them. What do they look like? They're really tachycardic. They might be very warm as well. And all like the hyperthyroid things that you think about, it's just on basically on steroids. Like they're even worse. And then I know there's an order for the meds you give, and I looked it up before. I just don't really remember them that well. I think you start with like the PTU and the propranolol, and I think at some point you're supposed to like give iodine. I don't know. I don't remember, truthfully speaking, but I know there's an order, and you shouldn't mess it up.
Yes, exactly. And they're going to honestly test you on they're going to test you in identifying thyroid storm, and they're going to test you on the actual order. So the way you think about it is they're hyperthyroid, they either miss meds, they have a trigger of some sort. Infection is the most common thing, but it could be anything. And so you have a massive release of these hormones. And so you get tachycardia, you get proptosis, you get a very high temperature. And that's kind of the presentation that like they will give you. Arrhythmia, things as such. They may be an AFib, that sort of a thing. And the way you treat this is going to be key. So the way you want to think about it is that these guys are like in hyper mode. Like they are like temperature of 104, tachycardia to the 130s. They're sweating. They look like shit. They're like psychotic. So you want to calm all of that down first. So you first give beta blockers. That's the first thing you do. Propranolol, beta blockers, you give that first. Not only do they decrease all of that hyperactivity, but they also block conversion of T4 to T3. T3 is the active form that gets used. So they're going to block it. Okay, great. The second thing you give is either PTU or methimazole. PTU is typically the safest thing to give because it's preferred in pregnancy. And methimazole has like another complication that I can't remember, but PTU in general works better. It works faster, and you don't have to worry about it in patients who are pregnant. So it's beta blocker first. Then you're like, now let me take care of the thyroid stuff. So you give PTU, okay? Then you give iodine. You never give iodine first because then the iodine will be used to make more thyroid hormone and it will be bad. You're just going to make it all worse. So you give the beta blocker first to reduce the hyperactivity. You get the PTU first to block any thyroid hormones being made. You blocked it now, it's done. Now you can give iodine. And that's going to, through a feedback loop, make sure that there's no more thyroid hormone released. And then steroids, throw them in anywhere. Doesn't really matter. The main thing is don't give it first because you have to give beta blockers first. And the second main thing to remember is iodine has to go after the PTU. It can't go before. Those are the two key things. And if you remember those two key things, you'll be able to pick what the order is and you won't have to like memorize which one is which. It's just those two key parts. Again, if there's any questions, please stop me because I will just ramble. But okay. Iodine is all of these things. Just something to keep in mind. They will throw any of them at you. You never give a thyroid patient aspirin because it will actually lead to an increase in the free thyroid level, hormone level. So don't give these people aspirin. And then you have the opposite of thyroid storm, which is myxedema coma. So what do these people look like? I know it's on here in front of you, but still, what are these people looking like and what are the key things to remember? These guys are the opposite. They're the opposite of everything. So they're bradycardic, they're hypotensive, they are hypoglycemic, they look just run down, they have a huge tongue, they have fluid everywhere. There's just fluid that gets released everywhere. There's like third spacing of everything, okay? So that's kind of the big thing to remember there. And for these guys, you have to give them IV levothyroxine, which is T4. You don't give them T3. Giving a person T3 can lead to very bad cardiac arrhythmias. They're super young, they have no heart problems, you can do it, but in real life, you don't want to be giving these people T3. It can lead to a lot of issues. You always give them T4, which is levothyroxine. This is also triggered by sepsis, trauma, some other thing. Both of these things are a person has a thyroid issue, and then there's some sort of triggering factor, and then it leads to either this or it leads to that, depending on what's going on. The parathyroid, go through really quickly. The key thing to remember here is that this is related to calcium. So anything parathyroid is calcium related and is phosphate related. And calcium and phosphate are going to be like inversely related in a way because they're going to bind each other. So, okay, so hyperparathyroidism, you have high PTH, so you're going to increase the calcium. You're going to reabsorb more calcium. That's what PTH does, okay? So when the PTH is high, the calcium is going to be high. And then in turn, because the calcium is high, your phosphate is going to be low because the calcium is going to start binding all of the phosphate. Perfect. And typically hypoparathyroidism happens because they had thyroid surgery. And so they also remove part of the parathyroid gland. Another key thing to remember. Electrolytes. Let's talk about electrolytes. Okay. Here's another question. So 60-year-old male, lung cancer, presents with altered mental status. He has diminished reflexes. He has a shortened QT. He's tired. He's thirsty. He's peeing a lot. What are you going to do? Someone throw out an answer. Whatever looks good. Whatever looks good.
It's hard because I don't have any vitals or anything. I just have like a shortened QT. So I'm honestly not 100% sure, but I'd probably start with fluids.
Yep.
He's really thick and he's urinating a lot, so he might be volume down.
Yep. You start with fluids. The key here is that this person has decreased DTRs. They have lung cancer, which makes you think of a possible calcium related issue. They have
There we are.
So you're worried about hypercalcemia here. Shortened QT interval. The majority of the electrolytes that are going to be hyper are going to have short QTs. So that's a big thing to kind of think about here. These are very general symptoms. You're going to start to realize that a lot of these things are just general things, and there's some keywords that you have to pick up on to realize, is it hypercalcemia, is it hyperkalemia, is it hypernatremia, and you'll kind of think about these sorts of things. So the key things to remember with hypercalcemia is they talk about groans, moans, psychiatric overtones, like there's that whole thing, stones. So it's basically like pain, constipation, kidney stones, they're psychotic, they're altered, they have bone pain, all of this sort of thing. And you want to think that they have a short QT as well. And then the treatment, what is happening? The treatment for this is lots and lots of fluids. If you're worried about hypercalcemia, the most common cause, by the way, of hypercalcemia is cancer, lung cancer more so than anything else. That's the most common reason why people in basically Cornell area C will show hypercalcemia. It's because we see so many cancer patients there. So treatment, lots and lots and lots and lots of fluids. A number greater than 14 is concerning. If they are showing symptoms, that's concerning. So lots of fluids, lots of fluids. Then you want to give loop diuretic so you can get rid of the calcium. So Lasix is good with that. Also, you're going to be giving these guys a ton of fluids, so it'll help you maintain that. Calcitonin is helpful. If you think it's secondary to a malignancy, bisphosphonates can be helpful. And then always remember that with any of these issues, with the hypercalcemia, natremia, kalemia, HD is always something you have to think about. If they're looking bad, what are the actual indications? If they have vital sign changes, if it's a really high number, if they're altered, if they're confused, if their body parts are failing, you just have to remember anything extreme within your question and in real life is something where you have to think about HD. Do I need to get rid of this quickly out of them? As opposed to, let me give them a bunch of fluids first and see what happens. You have to think about it if you have to act quicker than that. Does anybody know how hypocalcemia presents? what the like classic signs are. This hypercalcemia is neuromuscular depression. It's the groans, moans, stones, psychiatric overtones. What's the hypercalcemia?
The signs I remember, they have like some specific names, like when you brush the side of the cheek. It's like the and the blood pressure cuff sign. I forgot what they're called. One starts with a C. I
Love it. There's Schwafstick sign. This is the one with the facial nerve twitching. And then there's Trousseau sign, which this shows up in a lot of different things, not just hypocalcemia, but this is the one with the blood pressure cuff. This is neuromuscular excitability. So you'll get tetany, you'll get cramping, you'll get paresthesias, you'll get these signs when you tap stuff and you do the BP, you'll get. So anytime you see anything like that, think about hypocalcemia. And then reasons why you might get hypocalcemia are listed here. MTP is one of them. Hypomag is one of them. We always talk about checking magnesium for be it calcium, potassium, because you want to replete that. Otherwise, you won't be able to replete any of these guys. If you have a lot of phosphate, we already talked about how phosphate and calcium bind each other. So if you have a ton of phosphate, it's going to bind all of the calcium. So you can get hypocalcemia that way. The hypos get prolonged QTs. So remember that. And the way you treat this, you give them calcium. And then if you're giving them calcium, nothing's happening, then you should give them mag, because it probably means they don't have enough mag. And you go from there. Okay. Great. So we said that hyper levels of most of these things will lead to QT prolongation. Do you know which one does not lead to QT prolongation out of these? Hypercalcemia, we already know. Hypercalcemia, the hypercalcemia and these ones will lead to a shortened QT. Which of these, when they're hyper, will lead to a prolonged QT is what the question is asking. It's phosphate. And the reason goes back to what we were talking about before, which is when you have hypercalcemia, you have hypophosphatemia, you're going to like relate to the other one that way. So if you have hyperphosphate, then you likely are going to have low calcium. And so you're going to have a QT prolongation there. Phosphate, quite frankly, there isn't much that I would worry about too much. You're only going to get a few endocrine questions on the test anyway. Are they really going to show you, throw you a phosphate question? Probably not. Just to remember the relationship between phosphate and calcium, I think that's one of the main things. And then the signs and symptoms related to it are kind of everything. They're just very general sort of findings. If it's hypo, you give it back to them. You give them K-phos, Nutrifos, etc. If they're hyperphosphate, it's just basically treatment to just help them. You basically check to make sure that they don't have hypocalcemia. So poor phosphate, nobody really cares. They really cared about the calcium as opposed to anything else, especially when it comes to the test. Now, SIADH. So can somebody tell me what ADH does? What's ADH? What is antidiuretic hormone? What's its story? Okay, so we said that aldosterone brings sodium back into the body, and then the water follows, and it gets rid of potassium. ADH just gets water back in. It has nothing to do with the sodium. It doesn't have anything to do with that. It just brings water back into the body. Okay, so SIADH. Which of the following regarding SIADH is correct? You get it when you drink a lot of water. It's characterized by hypervolemic hyponatremia. Hyperthyroidism is the most common cause. You treat it with fluid restriction. Or lastly, the urine osms are low. Which of the following? Just hit me with an answer, whichever one.
Hypervolemic hyponatremia.
That's such a good answer, honestly. It's not the right one. It's with fluid restriction, but I'm going to tell you why that is the answer that I actually picked too when I first read this question, because that's exactly what because you're thinking about it the right way. So essentially SIADH is when you have increased ADH. So we talked about our character, ADH. ADH wants all the water in. It's like, give me all the water, right? So when it's getting in all the water, right, it means that you're going to have a low serum osmolality. You're going to have a low serum Na because you're bringing in water. So you're diluting the serum. Now you're bringing in water from the kidneys, right? Which means that your urine is not going to have much water in it. So your urine is going to have a lot of sodium and high urine osmose. So that's the way to think about SIADH. Again, like, I don't want you guys to try to like memorize any of these things. I just want you to think about what the character does. And then because the character does that, what does that probably mean for the rest of what's happening? Now, diagnosis wise, these are the things then that you're going to remember: the low serum osmolality, the low serum sodium, etc. These guys are usually euvolemic, which is not something that would like naturally come to mind, but these guys are typically euvolemic. They're not hyper or hypofluid, either way. And the way you treat them is fluid restriction. It makes sense. These guys have a ton of water in them. Stop the water. You just don't want them to have water. Okay. Diabetes insipidus is the opposite. So we talked about SIADH, CADH. I think of it as C like yes. CADH, lots of ADH. Yes, ADH. Opposite is DI. Okay, diabetes insipidus, low ADH. And there's two types. There's central and there's nephrogenic. Stuff is so fascinating. So central, you have low ADH coming from the posterior pituitary. So you tell your story again. The ADH is low, which means there's not a lot of water coming into the blood, which means that the urine will be super dilute because you're losing a lot of water, but the serum will not be that dilute at all. It'll be super concentrated. Okay. You treat the underlying issue for this. There's usually some other cause of this. And then you give DDAVP, which is basically like giving them vasopressin back, and vasopressin is basically ADH. So you're essentially just giving them vasopressin back. You're like, you don't have enough ADH? Here's some ADH that I made, and you give it back to them. Okay. Nephrogenic, the issue is that the ADH can't act at the kidneys. So you got ADH. It's just that where they're supposed to act on the kidneys, they can't act. Lithium is a common cause of this. So there are definitely Roche review questions related to lithium being related to this. And for this, you have to treat whatever the underlying condition is as well, which is the answer for most of these endocrine things. We talked about that with the thyroid. We talked about that with everything else. So even here, with these guys, you'll usually give them HCTZ, etc. Because these guys basically have ADH. So giving them DDAVP is not going to do anything because they have it. It's just that it's not acting on the receptors. Questions? This is just a handy dandy chart that you can look at later. Again, you don't need to memorize this chart because you know the story. Sodium. Okay, so hypo and hypernatremia. Hyponatremia, causes and symptoms. That's blank. Don't know why that happened. So hypo is something that we see in the ED a lot more of, I feel like. So what's the classic presentation for a patient who is hyponatremic?
The cases I've seen, they were altered. Like very little information, just altered. Usually from Gracie Square or some other like nursing home or something. And we had to figure out why.
Yep. Older patient, nursing home, comes in altered, right? And when it comes to sodium, the thing I always tell people, the first thing you have to think about is, do they look euvolemic, hypovolemic, or hypervolemic, right? And this, I think we make that more complicated in our head than we need to. Hypervolemic means, do they look volume overloaded? Do they have fluid everywhere? Do they have fluid in their lung? If they do, then you're going to fluid restrict them regardless, and you're going to treat their CHF for their renal failure or whatever the issue might be. If they're hypovolemic, that's also not rocket science. Are they hypotensive? Are they showing signs of not having enough fluid? If so, you should give those guys some fluid back. You have to be careful, but you should give them fluids. And everybody else, you're just fluid restricting them. Just don't give them fluids. You're just fluid restricting them. Okay. The classic teaching is that the serum sodium level should not increase by more than 10 to 12 during the first 24 hours for fear of osmotic demyelination syndrome. So the key to osmotic demyelination syndrome is to remember that if there's a person in your question STEM who has this quadriparesis or paraparesis, that's when you think about it. A lot of these people will be altered. They'll be looking confused anyway. But if they show any of this and they rapidly, corrected their, and if they rapidly corrected their sodium, then you want to think about this. And then the other key thing here is if a person has a sodium less than 120 or they're seizing, right? In real life, when are you going to give a person hypertonic saline?
Pretty much seizing or severe altered mental status.
Right. Arrhythmia, that's really bad. That's going to kill them. Seizing, you're just going to give it. And then if they're super altered, right? For any of those three things, you're just going to give hypertonic saline, especially when they're seizing. You're just going to give it until they stop. And you're not worried about this correction in that case. People always get scared. They're like, should I give more? You give it until they stop seizing. That's when you keep going with it. With altered mental status, it's a little less clear. You don't just keep giving it until they're not altered anymore. It doesn't work that way. But there's specific doses, and we basically talked to Renal about those to basically get that. But for seizing, you keep giving it until they stop seizing. There's a treatment for ODS there. It's not really high yield, but it's there for you. Hyper sodium. What you want to do is basically you want to replace the free water deficit. Typically, you want to give D5 water. You can just let them drink. Just depends on where they are, how bad they are. Too rapid correction of this leads to cerebral swelling. So the other one led to shrinking, and that led to the paraparesis. That one led to the quadriparesis and the paraparesis. But this one leads to swelling of the brain. And so these guys won't get the quadriplegia, the paraplegia, etc., but they're going to get everything else otherwise. So that's kind of how you tell the difference between these two. Okay. Let's do this one. 13-year-old female, nausea, vomiting. How am I on time? I'm okay, I think. Okay.
Do you want me to give you like a 5-minute warning when we're getting there?
That'd be awesome.
Okay.
Thank you. What is happening? Why isn't it working? Whatever. So 13-year-old female, nausea, vomiting, belly pain, fatigue, dry tongue, vomit. Sodium's 129, potassium is 3.1, bicarb 6, glucose 320, pH 7.2, PCO2 12. What are you giving this person along with fluids, and what's going on with them?
So this appears to be DKA.
Yep.
And I would be giving this patient potassium.
Yes. Why are you giving them potassium?
So
Their potassium seems fine.
Oh, stop it, you silly goose. No, you get sorry, it's late, so my brain's not functioning.
No, I know you guys are
Potassium
doing
level, the potassium level is lower than you believe it to be.
Yes, exactly.
Which
And
magic hands out. Yeah.
And people with DKA, it'll look like they have normal potassiums and they don't. It's just because of the fact that potassium, sodium, everything is moving in and out of the cells, and it's not in its accurate form. So with DKA, in terms of real life and in terms of the test, you'll hear about the way these guys look very sick. They can have pHs as low as like 6.8, right? They can have these Kussmaul respirations, which is the way that they're breathing. They're going to have elevated glucoses, though not as high as a person that is going to have HHS. These glucoses will be like 200s, 300s, 400s typically. They're not super high, but they're going to have an elevated anion gap. They're going to have ketones. They're going to have a low pH. They're going to have a low bicarb. They don't have to have all of these. They can just have some component of them, and you have to keep it in mind. The key thing for these guys is you give them fluids. You are going to give them insulin, but before you give anyone insulin, you always check the potassium. This is a huge real life thing too. That is the number one way you're going to kill them, because you're going to start to actually give them insulin and they are already hypo-K, and you're going to make them even more hypo-K. Okay. So essentially you can start the insulin if the K is greater than 3.3. You will replete the K if it's less than 5.2. So within this range, there's this perfect kind of algorithm in terms of how much you want to give and put into the fluids. Okay. And then you're going to give sub-Q insulin, insulin drip based off of the anion gap. You do it until the anion gap closes. In real life, this has not been holding true anymore. These patients always used to go to the ICU. These case patients would always get insulin drip until they close their gap. We're not always doing that, but this is practice, and you should still know that that's what's going on. You don't really give these guys bicarb. There's a bunch of people always talking about if their pH is like 6.8, should you start to give it to them? What should you do? Be my guest. I don't care. Whatever you want to do. There's really no data that's good either which way. But you're not really supposed to. It doesn't matter. Okay. Then you have HHS, which is different. This is also diabetes, and they have some sort of a stressor, a fever, an infection, MI, something, something, something. These guys are not usually that acidotic. These guys usually don't have ketones. These guys' bicarbs are usually okay. They usually actually look fine. It's usually because they haven't taken their meds. That's the majority of the time that we see these patients. But they usually have like really high glucoses, like 500, 600, 700s. These guys, fluids, tons of fluids. That's the main thing here. That's the main thing here, is that you want to give them fluids. This one just goes into, again, just showing you how these kind of vary. We already talked about that. The sodium is going to drop for these TKA patients as well. Don't try to give them sodium in some way, or don't try to do anything like that. It is natural that your sodium is going to drop for every 100 of glucose above 100. So you can use this to calculate, but keep it in mind that you're going to see that naturally. You don't have to worry about it. It will auto-correct itself as long as you fix the glucose and the underlying issue. Okay. 60-year-old male, altered, nausea, vomiting, belly pain, binge drank 2 days ago, hasn't drank since then. These are his vitals. What's going on? What is the most likely thing that is going on?
Given the tachycardia and the binge drinking 2 days prior, probably some, most likely diagnosis. Hold on. Alcohol ketoacidosis would be my guess.
Yes, alcoholic ketoacidosis. The thing to remember with alcoholic ketoacidosis is these things. What are the things that are increased? You'll see ketones, anion gap, lactate, etc. The glucose, the key thing to remember here is that typically it's like a chronic alcohol user who like binge drank and then stopped and wasn't eating and then comes in looking like sick. And then this is when you want to think about it. The main thing with these people is that even if their glucose is normal, you give them glucose. It should be a part of whatever answer that you pick. You're going to give them glucose. You give them glucose, you give them thiamine, you give them the whole thing. Okay, so that's alcoholic ketoacidosis. Okay. Respiratory metabolic acidosis, alkalosis. I'm not going to go through that much. It's right here. You can look through it. I want you guys to just keep these things in mind, like mud pile, like what are the causes of like anion gap acidosis? What are the causes of non-anion gap acidosis? There's all these hard up, God knows where people come up with this. A cat mud pile, there's hard up, there's me, you die. These are the things that have osmolar gaps. Whatever helps you remember what these things are, it'll be helpful on the test, because if they give you values or they give you numbers, then you can see, do they have an anion gap? Do they not? Oh, looks like they do have an anion gap. That's a cat mud pile. And then you'll go through and try to remember which of those things might actually be the answer. Okay. So these are the good things to just kind of memorize. So you have the mnemonic there. And then last but not least, talk to me about what's happening here.
Hyper K.
Hyper K. So on my oral boards, this was so, I felt so silly. So here I was taking them. This is my first case. I was nervous. I was like, man, oral boards, they're happening. It's my first case. It's me and the proctor. And they show me an EKG just like this. And I'm like, well, this is like VTAC, maybe VFib. It was like similar to this. And so I was like, I'm going to shock them. It's like, I'm going to shock them. It's going to be great. And I shocked them. What do you think happened next?
They went into cardiac arrest.
Literally nothing happened. They were like, nothing happened. And I was like, shock again, please. And then they shocked them again. And I was like, what happened? They're like, nothing happened. Patient's about to die. And I was like, and of course it was potassium. Of course I got it like the minute there. And I was like, Diksha, really? The basic of the basic. Remember to always fall back when you see an EKG and you see it look like this, it's potassium. If you see an EKG and a patient is bradycardic, it's potassium. If you see like any of these changes, anything that you see at all, the first thing you think about is it potassium? Okay, you have to think about, is it hyper K? That's always your first thought. Don't be an idiot like me. It all worked out fine. It was great. I am a board certified doctor, but hyper K should be one of the first things you think about. I always tell people when you have a female and she comes in with any symptom, she's an ectopic pregnancy until proven otherwise, right? Anything. And when I see an EKG, I'm always like, is this a STEMI? Is it hyper K? Always. Those are my first two thoughts. Okay. So what are some of the signs that you see? Peak T waves, P wave flattening, PR interval prolongation. Those are always the first few signs. I feel like PR interval prolongation people don't think about. It's a big one. Have definitely caught EKGs just because of this. And then you start to see everything kind of, they like talk about how if you took this like EKG and you kind of started to open it, like you took a string and you started to pull it apart, everything starts to widen and it looks like a sign pattern. And that's when you start to worry. What do you do?
Calcium, don't leave the bedside and keep pushing calcium till it narrows.
Yeah. You don't just give one dose of calcium gluconate and you're like, peace, I fixed it. No, the calcium, wait, was that just confetti? That's so strange. So typically you will give the calcium. You need to redose it every 20 to 40 minutes because that's just meant to stabilize the heart, right? Then you have to actually move around the calcium, which you do with sodium bicarb, albuterol, insulin. You give D50 with the actual insulin because you don't want to bottom them out. When they have renal failure, you should think of 5 of insulin as opposed to 10 of insulin. And then you think of how you're going to get rid of the calcium, how you're going to get rid of the K. Are you going to do it through low calma? Going to poop it out? Are you going to do it through loop diuretics? You're going to pee it out, K-exhalate? Or do these guys need to go to HD? Do you have to call renal emergently? You have to think about all these things.
Then you have a 3-minute warning.
Perfect. We're almost done. Hypo K, you see U waves. Do I have an EKG of it? Bad of me. U waves will be present there. They'll come with weakness, muscle cramping, fatigue. The symptoms you shouldn't be focusing too much on. Don't worry about what the symptoms are. Think about what the key things are that make each thing kind of what they are. What's the one thing that will help you separate hypo K from like hypocalcemia? Those are the things that you need to be like thinking about here. To treat hypo K, you're going to give them K. And again, if you give them K and nothing's happening, you need to give them magnesium. Hypomag might be an issue that this is happening. Hypermag, let me see. Yeah, okay, perfect. I will end this with hypermag. So hypermag, when do we see this the most in real life and on a test?
OB.
OB, yes. When in OB?
like for oh my gosh, why is my mind blanking? I just remember being really concerned about it on OB last year. I just don't remember the specifics. Sorry, like I said, my brain is a
You
little.
don't have to, no, don't be sorry. Eclampsia, patient seizing, you want to stop them from like actually going into like seizing. You're going to start them on a mag drip. Having friends who have been on a mag drip feels terrible. It's horrendous. You feel like shit. And you have to watch for these signs. These values should not correlate to what's happening here. Please don't like hold them to anything. This is just meant to tell you that first, the early sign is that you're going to lose reflexes. Then you start to get hypotensive. Then you start to get respiratory depression, dilated pupils, paralysis, et cetera, until you arrest. So if you see these signs, if you see a patient with these signs, who's an OB patient in the question, you need to be thinking about hypermag. And then what do you do with hypermag? You stop the mag. You give a ton of fluids. So hypercalcemia and hypermag are both very similar. Fluids. Also Lasix. And then you go from there. If it's severe hypermag, you give them calcium. And always remember, HD is something that you can do for any of these patients. This is more of a real life thing, but you want to make sure that if they look bad enough, if there's vital signs changes, if there's any issues, take them to HD. Any questions?
That is it. Thank you very much, Dr. Mishra.
Of course.